please welcome Dr. Umal Ssenkubuge.
It's always risky business to give a Ugandan 15 minutes to present, but Brant is a risk man. Hi, my name is Dr. Omar, and I have the awesome privilege of leading a team of young professionals down in Uganda. And we started a company called Preserve a Life. There's a whole spiritual thing about Preserve a Life, but our role that we thought was to use our talents to bring healing to the community. Now, the community that we chose is specific because it's not the everyday corporate community. The reason we call one of our projects Mama Namu is because Mama means mother, where we come from. And the burdens of the community, to take care of the community, solely rely on the mother. I am a product of that. And so, because of the economic situation of where we come from, healthcare is so expensive. So in a long run, this mother wears out and she becomes worn out. So we've created health products or a health system that takes care of this mother inexpensively. Now we have two categories of mothers. Let me spend some time here so that the rest of the presentation becomes easier. We have the corporate Mama Namu and we have the rather retired Mama Namu. And how I like to talk about that is my mother and my wife. My wife is the corporate. She earns $100,000 at least in Uganda. And that is, say, a teacher, that's a nurse, that's anyone corporate. But the responsibility of the house are on her. So she neglects her health because she can't afford to take care of herself. There's the older one, who is my mother, that is retired. She doesn't have a job. There's no national healthcare system. She doesn't have insurance. And now she is diabetic or she's hypertensive, right? So how does she get her medicines? That's what Quick Care did. And now Mama Namu focuses on giving her emergency medicine care in case she needs it. Are we on point? If we get that, then the rest becomes easier. So, oops. Sorry about that. So that's a description of Mama Namu. Highly fertile in terms of productivity. An average Ugandan has 5 children by the age of 27. Prime age, right? So there's a lot of obstetric emergencies that come into play. This is Tata Namu. Tata Namu is a boda boda rider. And that is what Brant loves to say, bada bada. So boda boda is the cheapest way of getting around, and this is thousands and thousands and thousands of young people being employed by this. What you see is an 18-wheeler in traffic. These guys are risk takers. With all this risk, chances of you dying in Uganda of anything else that could kill you are 78% that it will be a boda boda accident. If you have ever had anyone be in Uganda or East Africa, they'll tell you what risk takers these guys are. Now imagine all this happens without pre-hospital care. If you get an accident, if you get a heart attack, no one is coming. You're on your own. In Kampala alone, between 2023 and 2022, we saw a 15 rise in road traffic incidences, 574,000 government hospitals. This is from the National Registry. Only 5% of these came to hospitals using ambulances. 95%, how do they get there? Using the same. So you would get an accident and we'll put you on a boda boda and take you to hospital. I know that because I was on the other side of the hospital receiving them. This is the situation with primary health care. The World Health Organization recommends 1,000 patients to one doctor. Uganda has 25,000 to one doctor. As a doctor in the government hospital, it's not new that you'll see about 150 patients a day. It's expected of you, right? Now, these are the guys that come to government hospitals. This is the map of the beautiful Pearl of Africa, and this shows you papers that were studied to show you self-prescription. As a result of the inconveniencing healthcare, in the US, you can't go and buy antibiotics, right, off a pharmacy. In Uganda or Kenya, all you have to do is what is the strongest headache pain meds, and they'll tell you codeine, Vicodin, opioids, and you can get it over pharmacy if you can pay for it. They don't tell you the side effects that come with self-prescription. So that's what we try to address with quick care, right? Keep forgetting that this doesn't work. So over the years, 2018, this is what we have done so far. We have seen over 1 million patients on our system, on our primary healthcare system. Our annual revenue has accumulated to over $500,000 US, and this is from collecting from the Maama Nams. Our consultation is 20,000 at our clinics, and we make sure that you get your medicines, well, in under 30 minutes, right? So we took all this, and our learnings from all these years were that most of our revenue was coming from laboratory services and consultations. So with a new upping scale, mostly after COVID, Uganda was one of the countries that were in total lockdown longest. I think we were 1.5 years. People were not even allowed to get out of their houses, except for, of course, under special circumstances, if you had a medical reason. So then we started treating patients on Zoom. I think during COVID, that's when Zoom came up, really. Zoom and Google Meet. We made so much money that we realized that we could have saved so much money if we had ventured into telemedicine. So we closed about 3 clinics, 4 clinics. We only run at 2 physical clinics now, and we are going into telemedicine to try and reduce the expense and try and keep some money in the bag. And this is our system. This is the entire solution demonstrated. So now, most of we're actually fundraising now to finalize with our dispatch center, which is going to be our telemedicine command as well. So we can remotely treat people, make our doctors efficient using, of course, we have integrated AI solutions into most of our solutions to try and make them effective towards their app. So all a patient has is their app, and just like you'd be on Zoom, now you can talk to a doctor and then you get your medicines without having to come into the inconveniencing system. We'll charge them for that. Then we also have pre-hospital care. Our pre-hospital care focuses on response. We don't have the luxury of ambulances like you guys have in the US. So we focus on response and resuscitation. At least we will get you someone that is professional enough to preserve your life until you're stable enough for us to transport you to the nearest hospital. What we call emergencies back home are not what you guys call emergencies. My lieutenant is in the audience. We respond to calls where grandma fell and hit their toe and they called 911. We have heart attacks back home for accidents and no one is coming. You have mothers that are dying giving birth on the side of the road and no one is coming. So that is what we are promising people. By the time you're stable enough to get to the hospital, now we can manage the already available resources to get you to where you need to get to have help. How do we make money? Unfortunately, we are not a charity organization entirely. We have realized that for you to do charity, someone has to pay for it. And unfortunately for us, we have not been lucky enough to fund finding. So we have to generate our own revenue. So we are charging Maama Nam about 20,000 Ugandan shillings a month, prepaid. How do we make sure that she gets this money? Airtel companies, mobile money companies can trust her enough. I keep telling Brant that in the US, what you guys call your social security number, back home, that's my national phone number. Everything else is transactable there. You are doomed in Uganda if you can't transact using mobile money. And who has the control over that is a telecom company. So we have a lot of partnerships with them. They'll give you a loan of 20,000. That equates to about $4, $5, I think, a month. And now we can give you medicine and medical services if you need it, telemedically, right? If you need health insurance, we'll get that from insurers and then commissions from hospitals to where we take these patients when we respond. Again, we do not have a national care plan. In Uganda, if I treated you and unfortunately you passed on in a hospital, I would keep your body until I get my money. So your relatives would have to sell everything that they have until they pay for care. So we're telling people you don't have to get to that extreme, right? Pay up, make healthcare convenient and then cheaper for everyone. And most importantly is the training, mostly for the EMTs and the paramedics that we have. We've trained with the help of Brant here. Brant launched our first training for EMTs. We trained about 150 doctors. Again, they are doctors where they are. They do not have the skill to do what it is that they need to do. So my part of being here is to study. And as I study and sit in class, I also train a whole bunch of doctors back home. Value for money, right? Because it's not cheap. So these are projections. We're raising a first round of We're going through our first fundraising and looking to raise 300,000. That 300,000 is going to help us boost and finalize our dispatch center and then get some bikes for our EMS. And again, develop fully the systems that will coordinate with our ambulances and the hospitals that we'll be responding to and taking our patients to. The projections, again, these are just predictions, but they're based onto the numbers that we are making. The idea is that if I have 1.6 million users in my system, with the telemedicine, I just have to target at least 120,000 of those in the country in the first year. If I get those and charge them about 21,000 or so a year, that will cost them about 170,000. They don't have to pay that money to me. The Airtel company or the telecom company will give them that loan and it will collect from them. I run away from the whole collection hassle because Ugandans, once you give them service, good luck collecting from them. And I speak for the greater Africa, right? Value is before we consume. The moment we consume, and unlike in the US, you guys can go to the hospital, they'll treat you and someone will pay for the bill. No, that doesn't work where we come from. So we have to collect first. Those are the subscriptions, right? But we also have commission from hospitals because again, we are not taking our people respond to our hospitals. We are taking them to other hospitals. In the US, it's illegal to get commission. Back home, they encourage it because we want to get people to hospitals. We're asking hospitals to only pay us 100,000. It costs them 2.8 million to send an ambulance to pick you. And we are only asking them to pay us 100,000 off you. Now, if you have this subscription, the beauty is that you don't get to be paid for this. So the idea is to get as many people to sign up for our products. Of course, insurance. One of my biggest pains in the US is having to pay for car insurance. And every time I tell people about my audits, they're like, you only pay $100? That's nothing. Back home, I pay $20 a year. And here I have to pay $100, right? So all the cars and all the border borders that are killing people on the roads, the government insists that they have to be insured. That insurance doesn't get them a thing. It's just a thing of, government to collect money. So the idea that we had with national car insurances is that add only 20,000 of this money and then we'll insure them with healthcare whenever they get issues. The idea here is to try and collect as much, but collect as less, right? So that we fuel whatever it is that we have to do. That's pretty much it. That's our team. That's my core team. I do the presentation, they do the work, to be honest. I do the speaking, but I have a whole support team, and this is our board. Our board is comprised of people that have done corporate work in the Ugandan structure, from banking to Ministry of Health officials to everyone. Everyone is excited. No one is willing to invest or has the money to invest. And that's why we are looking for some of these resources to do some of the things that we're doing. And you might know that person. That's just a simple profile about me. Thank you very much for your time.
That have some questions for Dr. Umal?
I hope not.
Yeah.
Are you partnered with any organizations outside Uganda right now?
That's what we are looking for. No. We have partner hospitals out of Uganda, mostly in the region, but we don't have any yet in the States or other regions.
Yeah, informal, that's like on the trading side. Okay.
Oh, we have partners. We have firehouses that have given us training support, and we are looking for more partners, mostly into the things that we are doing. Yes, sir.
You bring people to the hospital on motorcycles?
No. We respond, we resuscitate, and we are coordinating from the dispatch center who has an ambulance within until we can afford to have our own ambulances. So for now, that's how the dispatch is managing the resources. I wish we could put them on the bikes, but that would be malpractice. According to the standards that we are creating.
That's happening now.
Oh yeah, that's what is happening now. So what is happening now, you get in an accident and break your neck. Well, unfortunately, we have to take you to the hospital on a border. I know. Or the police shows up, police has these patrols that they sit back, so we can fetch you if you're lucky enough, and we'll throw you under a truck and take you to the hospital. That's why we're creating what we are creating, to try and reverse some of those deaths because we're saying they're avoidable.
So the current ecosystem there are national hospitals, other hospitals. There are some ambulances there that are underutilized because they're
Yes.
very expensive. They have to pay for that. There are urgent care clinics which you are already running.
Some of them, yes.
But even those are still out of price range for most people to use, and they don't handle the emergency type of situations.
Mm-hmm.
And so, in my mind, there's kind of two big things that you're doing. One, you're going to extend the preventative care through virtual care and adding a virtual platform, not just having off-the-shelf Zoom. It's built for the purpose.
Yes, which makes it cheaper for us to extend to more people.
Yeah, and then the second is the emergency care is bringing that to bringing the EMTs to
the field.
To subscribers, especially right. So the subscriber that since I'm a subscriber here, I get my virtual care, and I also have access to the emergency care where they come on the quotas, but they bring it to me, and then if I need an ambulance,
We can coordinate that.
coordinate the ambulance. It's not cost extra, but you're filling a big gap.
Because part of the pathologies of the system that we have, part of the problem is really there's no coordination. We do not have a national number that people can call in case there's an emergency. So much as we would like the Good Samaritan law to kick in and people to help, my people, I guess, perish because lack of knowledge, right? So people do not have the skill and the knowledge to save lives because no one is coming. And that's what we are bringing. So we are bringing the hospital virtually, and in case we need to come and get you, we can coordinate that. Yes,
If
sir.
you're looking for $300,000, are you looking for investors or
Anyway, so we're looking for grants, we're looking for impact-based funding, we're looking for venture capital investors, anyone that can get us money to do what we do, and then we can arrange, is it equity-based or is it impact-based?
we got I couldn't see the numbers, but we got a projection. So somebody writes you check that $300,000. You have a plan says this will be the ROI at the time it is projections.
Absolutely. We have a whole business model into that. Because again, part of this is to launch us. Brant has been helpful in making sure that the business is structured well, and that's why we graduated the Vitals program, so that now we can go before investors and present our business model.
So the $300,000 that buys some protocols, it also procures the platform, the virtual platform, which only exists here. So that's not the partnership with more, and so the infrastructure to have the virtual platform. And the initial dispatch. So it could be with kind of in some marketing. Like so the idea is year one, you convert some of their current 1.6 million of
the physical subscribers
in the care physical debt over the past 4 or 5 years. And so the first goal would be from a marketing standpoint, you convert some small percentage of the 1.6 million. If you had 100,000, 120,000 of those, that would be on subscribers. Yeah. And then that's your additional revenue that first year. You're projecting actually a profit in
the first year. Because again, it's a revitalization of an already existing business. Yeah.
You see it, so it's a street like example. So one of the things you said was that if care is provided, making this a flexible platform, and if you see an issue with trying to get people on a regular billing subscription, but they're coming from economy and working out bills.
So the idea with the unique advantage about our model is that we want to collect before, but what would have been, for example, a consultation where I come from is 150,000, which is give and take $40 to see me. Now, that's one visit. That's what our corporate private hospitals charge. If I ask you for that and I ask it annually, right, I am telling you that pay this and you have this care. If you do not consume, that carries forward into another year. But from the data that we have, we know that based on your determinants of health, you are going to consume, either through primary health care. So you have malaria. Our healthcare problems are a 4-decker kind of layer. We have communicable diseases. What Brant and I always say, the non-communicable diseases. The Western world has realized bringing fast foods into Africa is a good idea. And for us, that's where the rich eat. That has opened up a whole canister of non-communicable diseases. So now obesity, hypertension, diabetes are happy low. So we know that you will need that medication filled every month. On top of that, you have the pandemics. COVID showed us if any of those things, that you better be prepared. And then the accidents and emergencies that are happening around you. So off that deck of stack of problems, you are predisposed to 78% chances, at least one of them. So that's how we are preparing to cushion that. So collect before you consume, but also we know that you will consume. And if you don't consume, it carries forward. And we have other things in there like family packages, corporate packages. We have different modalities for schools, for example, to make sure that, okay, how do we take this to schools so that we can give school-going people support as well?
Working of a healthcare subscription.
Yes, there's insurances. There's insurances, but it covers about 5% of the 49 million people. But then Uganda is a very communal society. So people have small circles that will pull up money together and then they can pay communally for someone in case they get a problem. Those are also good areas for a business model. Because again, the telecom company is who everyone congregates to. You're welcome.
So there's insurance, but there's nobody else that
For healthcare, no.
It's almost like an HSA. Yeah. Like a lot of those, some of those 1.6 million are corporate customers. Right.
Yeah, most of them are corporate customers. Most of them are embassies. We serve the American embassy and we do their wellness in most of the things for their local employees. Because then they have the expatriates, then they have the locals. Because of the density of the locals, we've been giving them support into our clinics. Now, they're asking, saying, hey, can this be virtual? Because it doesn't make sense for me to come in for a flu shot. They lose productivity. So things like that. The idea is get clusters and groups of people where they are paid for insurance, which is very small. The bigger majority is the Maama Namu, who does not have any kind of plan, any kind of care.